Today, it's a great pleasure for me to have with us our speaker, Dr. Claudia Campani. She's currently affiliated with the Department of Experimental and Clinical Medicine, particularly Internal Medicine and Hepatology unit at the University of Florence, and with the Functional Genomics of Solid Tumors unit at the Centre de Recherche des Cordeliers de la Sorbonne University. So today, she will be sharing some insights on circulating biomarkers of response to systemic treatments in advanced hepatocellular carcinoma. Her research spans multiple aspects of liver oncology, covering molecular mechanisms, biomarkers, and treatments. So I think that today all of us will gain some new insights related on these topics. So thank you again, Claudia, and the screen is yours.
Thank you, Davis, for the presentation, and thank you for the invitation. I'm very glad to talk about, in general, or about HCC, but especially on the circulating biomarkers. I'll try to put in presentation way. Okay. So just a brief introduction. As you know, hepatocellular carcinoma represents 90% of primary liver cancer and is the third most common cause of cancer-related mortality. And each HCC is a unique combination of genetic alteration and epigenetic alteration, and its development is shaped by tumor microenvironment. And the new next generation sequencing techniques have improved a lot our knowledge about HCC. And now we know that its tumoral burden is about 2 to 9 mutations per megabase, that it's approximately 40 to 60 somatic genetic alteration in protein coding genes. But not all these mutations are important for the HCC development, as most of them are passenger mutation, and only 2 to 6 mutation occurs in gene that drive the liver carcinogenesis. And we know 6 main biological pathways that are involved in the development of HCC, and the most frequent is the telomere maintenance, that is with mutation in third promoter in approximately 60% of the cases, but that may involve also mutation in the gene, in the exon 1 in particular, and amplification of the gene. The Wnt beta-catenin pathway with mutation both in the CTMBB1 gene, but also in the APC and AXIN1. The cell cycle gene may be involved, especially with mutation in RB1 and TP53. The part of the epigenetic part, so with mutation in ARID1 alpha or the MLL family. The oxidative stress pathway with the NF2L2 and the RAS-RAF MAP kinase pathway and the mTOR pathway. But not all mutations are represented equally across the BCLC stage, that, as a reminder, is the most widely used classification for hepatocellular carcinoma. And we know that third promoter mutation is approximately expressed equally across all BCLC stages, so from BCLC 0 to BCLC stage. And conversely, the CTMBB1 mutation, it's found approximately in less than 20% of BCLC 0 stage, so the very early stage of HCC. It increased to the BCLC B stage, and after that, the trends stabilized. And so we don't have a lot of mutation in the BCLC B and BCLC C stage. And it's the opposite for TP53 mutation, where the rate of mutation increased progressively from the very early to the advanced stage. And in the same work from the lab that tested tumor with whole exome sequencing, we tested 41 advanced HCC and 156 early HCC that were resected. And we observed that in the advanced HCC, so in the 41, we were able to find all the classic driver genes mutated in HCC, but we observed an enrichment in TP53 mutation, RB1, and dysplasium machinery. So the HCC is a unique combination, but it's not important only to be an HCC to have some genes mutated, but also the stage of HCC. And in the last year, the landscape of systemic treatment for HCC has deeply changed. And now we have 7 different drugs or combination of drugs that we can use for patients because they have shown survival benefit for patients when used as first, second, or third line. And in particular, we have the new one, atezolizumab bevacizumab, that is a combination of an anti-PD-L1 and antivascular endothelial growth factor. That is the new first-line standard of care for HCC. That is, and it's used as first line because it overcomes sorafenib in the IMbrave trial in terms of overall survival, progression-free survival, and objective response rate, and also quality of life reported by patients. But despite the good results in terms of overall survival and progression-free survival, the objective response rate did not exceed 30%. And this is thought to be related to the intratumor heterogeneity, the intertumor, and also interpatient heterogeneity. So not all patients are likely to benefit from atezolizumab bevacizumab, but currently we don't have any instrument, any tool that can help us into recognizing patients who are more likely to respond to this treatment. And these tools are needed not only to the expected outcome in prescribing the correct treatment strategy to the patients, but also because it could help us also to reduce the unnecessary and severe adverse events in patients who don't need that drug, and at the same time could help us into reducing treatment-related costs. And various biomarkers have been evaluated during the years, but currently only one biomarker has been validated, and is the baseline alpha-fetoprotein for patients who are treated with ramucirumab as second line after sorafenib. And so in the last year, I decided to focus my research on circulating biomarkers in HCC, in order to identify these circulating biomarkers to guide systemic treatment prescription, at the same time finding something that could recognize promptly response or progression to treatment, and so help us into modify the treatment strategy. And so it's quite obvious, the alpha-fetoprotein, it's the most widely used biomarker in different treatment for HCC. So we know that it's important and taken into account into transplantation, in resection, and also in systemic treatment. But in systemic treatment, it has been explored in a different way. We know that when we prescribed a systemic treatment, patients after 8 to 12 weeks, he undergo an imaging to evaluate the efficacy of the treatment. But even if the imaging evaluation is after 8 to 12 weeks, we clinically follow the patients and we perform blood tests. And most often in the blood test, there's also alpha-fetoprotein. And so in the field of systemic therapy, alpha-fetoprotein has been evaluated not only at baseline, but also its dynamic. And regarding sorafenib and immune checkpoint inhibitors, it has shown that a reduction of 20% of alpha-fetoprotein values from baseline after 3 weeks may help into predicting the survival and progression-free survival of patients. And so this was done for the sorafenib and immune checkpoint inhibitors. And so we decided to do the same with atezolizumab bevacizumab. We included 5 patients treated in 3 different centers, 2 French and 1 Italian center. But we excluded 30 patients because the alpha-fetoprotein values were lower than 20 nanogram per milliliter. And so we had only 75 patients that we divided into a derivation cohort and a validation cohort. These are the main characteristics of the patients. So 73% of patients were cirrhotic, and the most common cause of liver-related disease was hepatitis C virus infection and chronic alcohol intake. And regarding liver function, most of patients were childhood A and ALB2 grade, and most of them were BCLC stage. We decided to explore if there was a cutoff in the alpha-fetoprotein reduction or better dynamic that was able to help us into predict the radiological response. So if there was something that could help the clinician before the imaging into predicting and say, okay, this patient will respond to the therapy or not, and constructing the ROC curves and calculated the Uden index, we observed that a reduction of more than 20% of the alpha-fetoprotein from the baseline at 3 weeks of treatment was the best cutoff to predict radiological response. And even if with a less predictive power, it was able also to distinguish patients who could obtain a response and stable disease at 12 weeks. So we decide to classify patients according to the reduction or no reduction in alpha-fetoprotein, and both in derivation and validation cohort. And as you can see, among the patient who experienced a reduction in alpha-fetoprotein values, 42 were responders at the first imaging evaluation, in contrast to the 5% who had no significant reduction. And the same results were confirmed in the validation cohort, where the 58% of patients whose alpha-fetoprotein was reduced had response, in contrast to the 11% of the group without significant reduction. We wanted to see also if there was a prognostic role for this dynamic of alpha-fetoprotein, and both in the derivation cohort and in validation cohort, the reduction of alpha-fetoprotein was able to identify a group of patients with a longer overall survival, and the alpha-fetoprotein early reduction was the only factor independently associated with overall survival at the multivariable analysis. In the derivation cohort, it has a role also in terms of progression-free survival, but these findings were not confirmed in the validation cohort. And after that, we decided, okay, alpha-fetoprotein, it's a good biomarker probably for predicting the prognosis of patients treated with atezolizumab, but we know also from sorafenib and other treatment that is not sufficient. And so we decided at the beginning to look at the other factor that could have an impact on the prognosis of patients. And this is the ALB score, in our cohort at least, that is a combination of albumin and bilirubin that predict a little bit better than Child-Pugh score, the liver function of the patients. And so we combined the ALB score and the alpha-fetoprotein response, and we were able by this combination to identify 3 groups of patients with a good prognosis, with different prognosis. So patients with ALB1 and alpha-fetoprotein responder that have a good prognosis in terms of overall survival and progression-free survival. A group with the intermediate prognosis that were patients responder and ALB2 or non-responder and ALB1. And a third group that had a very poor prognosis, that was the group with the ALB2 liver function, a liver function classified as ALB2, and alpha-fetoprotein non-responder. But it's enough to have the alpha-fetoprotein and the ALB score there should be something that can help us more to identify these patients that are able to respond to a systemic treatment compared to another one. And so for this reason, we decided to move to another field, more translational field, that is the field of liquid biopsy. And we know that with the term liquid biopsy, we refer to a group of components that are released in the bloodstream, so circulating tumor cells, circulating tumor acids, microRNA, and exosome. And regarding circulating tumor DNA, is a small percentage of circulating free DNA, is a double-strand DNA of 150 base pair that is released from passive release or active extraction from circulating tumor DNA, circulating tumor cells or tumoral cells. And we know that is stable in plasma. And the circulating tumor DNA has several advantages. The half-lifetime of circulating tumor DNA is less than 2 hours, and so it may depict the patient oncological picture in real time. It's a non-invasive tool that could be used for serial assessment and that can reflect the genomic landscape of tumor when tissue is insufficient or unavailable. And this could be also so very useful in case of HCC, that we know that when we are facing with the cirrhotic patients with a nodule more than 1 centimeter in size that have specific features at imaging, we don't need biopsy for diagnosis. And so not every time we have tissue available. And moreover, it has been proposed, circulating tumor DNA, it has been proposed to overcome the limitation linked to the tumor heterogeneity, because in the circulating tumor DNA, we have all the circulating tumor DNA from all the cells from various tumor. And so we can really assess the mutational burden of the tumor that could be limited by a single biopsy sample. And several studies have explored the role of circulating tumor DNA in advanced HCC. This is a retrospective study that included 46 patients that were enrolled in the phase 1b trial for the approbation of atezolizumab bevacizumab. And the authors tried to correlate the level of circulating tumor DNA with radiological response, and they observed that in patients that had a very higher concentration of circulating tumor DNA, they progressed to the treatment compared to patients that have less higher concentration of circulating tumor DNA that were more frequently responders. And a recently published paper explored using the ultra-low pass whole genome sequencing, explored the presence of circulating tumor DNA into 37 patients treated with different systemic treatment. And they show that the presence of circulating tumor DNA that was defined like mutation in 16 genes that they explored, and was associated with a shorter overall survival. But most of these studies have several limitations that are the limited number of patients that have been included. And moreover, I think that the most important limitation is that the concomitant tumor is not analyzed. And so for this reason, we decided to conduct a study including both tumor and plasma sample. And we studied tumoral sample using ultra-deep target sequencing, searching for mutation in 39 different genes. And we wanted to explore also the role of digital droplet PCR. So TERT promoter mutation were assessed also using digital droplet PCR. And tumor, the gene expression was evaluated also with quantitative real-time PCR using a panel of 283 genes. And plasma sample, we didn't cover the 39 mutation that we explored in the tumor, but we focused on the 5 most altered genes in HCC, and we explored third promoter mutation as well with digital droplet PCR. So we included a total of 229 patients, of whom 56 patients had no HCC. And this was to compare and to explore really which could be the role of circulating tumor DNA in patients with HCC compared to patients without HCC. And we had 173 patients with HCC, and for each patient, we collected at least one plasma sample for a total of 772 plasma samples. And these plasma samples were further divided into 3 groups. So a first group of 502 plasma samples that were collected when patients was treated. So we call this group active HCC. 154 plasma samples were collected 24 hours after a local regional treatment, and 116 plasma were collected in a patient that was treated for HCC, so a patient with a history of HCC, but the patients obtained a complete response. So when we collected the plasma, tumor was not detectable by imaging. And even if the focus of today's presentation is systemic treatment, I think that we need 2 words to explain really which could be the role of circulating tumor DNA. So at the beginning, we start trying to show that circulating tumor DNA could be important because it's in patients with active HCC, because its concentration is significantly higher in patients with active HCC compared to the inactive group. And if you look at the right of presentation, you can see that in the group with active HCC, we have a higher, significantly higher percentage of mutated plasma compared to the inactive group and the control group, with some sample that were mutated in 3 out of the 5 genes that we studied. And regarding the type of mutation, was true in general for third promoter, CTMBB1, and TP53 mutation, with mutation that increased from the control group to the active group. And the most important part was to assess which is the concordance of the circulating tumor DNA analysis compared to the tumor. So in the alluvial plot on the right of the slide, you can see the concordance of third promoter CTMBB1 and TP53. On the right, we have tumors, and on the left, we have circulating tumor DNA. And there's a quite good concordance, even if not all the mutations were found in plasma, but this is, we will see, related probably to the stage. But in the plasma, we were able to find also some mutation that were not detected in tumor, probably because we biopsy part of the tumor that was not mutated, but really the tumor has also another type of mutation. And we know that HCC can be divided in 2 big groups, the proliferation class and no proliferation class. So the proliferation class is a group of HCC that is more aggressive. So there are usually HCC with a poor prognosis that are related more frequently to HBV and that are characterized by TP53 mutation and the transcriptomic group G1, G2, and G3. Conversely, the non-proliferation group, it's composed of the G4 to the G6 transcriptomic groups, and G5 and G6 transcriptomic groups are enriched in CTMBB1 mutation. And so to explore also the distribution, we wanted to explore and the concordance of tumor and circulating tumor DNA. So we looked at the G1, G6 transcriptomic subgroup in circulating tumor DNA. And so we observed that third promoter mutation among plasma that were mutated for third or not mutated for third, there was no difference in the expression of G1, G6 subgroups. But when we look at the beta-catenin, we have thought that beta-catenin group is G5 and G6 transcriptomic groups are enriched in beta-catenin group. And when we look at the plasma mutated for beta-catenin, we found that the concomitant tumor was G5, G6. And similarly, when we looked at the circulating tumor DNA mutated in for TP53, we found that the concomitant tumor was most frequently G3. And similarly, we made with another molecular tumor signature that has been developed in the lab, that is the 5-gene score that classify with the expression of 5 genes HCC into good prognosis and poor prognosis. And we observed that the poor prognosis was associated with plasma, as known, mutated in TP53. And why we decided then to focus in our attention on the role of circulating tumor DNA in advanced HCC? Well, because we observed that it's in the BCLC stage, so in the advanced stage, that we have the higher frequency of the higher concentration of circulating tumor DNA, and it's in the BCLC stage that we have the higher frequency of mutation. So probably the circulating tumor DNA or the techniques that are available today are not enough sensitive to use the circulating tumor DNA in the very early stage, but circulating tumor DNA could have a role in the most advanced stage. And in this part of the work, we decided to compare the circulating tumor DNA to the alpha-fetoprotein that nowadays is the most widely used. And so in the x-axis, you will see the BCLC stage, and on the y are the 8 of the bar represent the percentage of plasma that are mutated. So in the BCLC stage, we have approximately 70% of plasma that are mutated, and the color represent the value of alpha-fetoprotein. And so, as you can see, when at least 1/3 of plasma sample that are mutated were collected when alpha-fetoprotein was normal. And so it highlights that circulating tumor DNA could have a role in improving alpha-fetoprotein, because it could be used also when alpha-fetoprotein is negative. And the pattern of mutation that we found in circulating tumor DNA is the same that we found in tumors. And as we have told before, the mutation of beta-catenin increase from BCLC0 to the BCLC-B stage, and after that, the trends stabilize, and this is what we have found in plasma. And for TP53, we had in tumor an increase from BCLC0 stage to the BCLC-C, and this is what we found in plasma sample. And so after that, we focused on patients treated by systemic therapy. And to do that, we analyzed 356 plasma samples that were collected in 53 patients who underwent a first-line systemic treatment. And this approximately the percentage of mutation that the plasma that we found was mutated was 60%, with higher frequency for third promoter, TP53, and after CTMBB1. And then we focused our attention of the patients treated by atezolizumab bevacizumab. We had 35 patients, and in particular, we focused on the 19 patients in whom we were able to detect a mutation in the plasma that we collected at the start of the treatment, so at the first cure. We followed the patient on the time over the time, and we have a plasma sample available every 3 weeks till the radiological evaluation. And we observed that patients who the first imaging evaluation obtained a disease control, so a radiological response or stable disease, the mutation that we were able to detect at the baseline was disappeared at the first radiological evaluation, and conversely, in patients in whom the mutation that we detected at the baseline was present, at the first imaging evaluation, they progressed. And this is the same concept as before. So patients are divided into response, stability, and progression. And as you can see, this is to highlight that we wonder why patients who obtain stable disease at the first imaging control, the mutation disappeared, like for the patient that obtained at first imaging evaluation a response. And so we look at the second imaging evaluation, and we observe that 2 out of the 3 patients obtained a later radiological response. And we hypothesize that probably circulating tumor DNA is able to detect before the radiological evaluation, not only the response at the first imaging, but the disappearance of mutation could be also, could express also the response at the later imaging. And before concluding, I would like to present the cases of 2 patients that we included for whom we had plasma. The first is the case of a man with an HCV-related cirrhosis that underwent a first percutaneous ablation. We had the tumor, so we analyzed by ultra-deep target sequencing and also whole genome and whole exome sequencing, and we found that the tumor was mutated in TP53 with a classic mutation in TP53, and even if it's not frequently associated with the HCV infection, but it's a very frequent TP53 mutation, and we found also a MET amplification. After a few months, I would say patients progressed because he developed a metastasis, and so patient was treated with sorafenib. Patients progressed very quickly also to sorafenib after 2 months, and we had the plasma progression. And we were able to find the same mutation that we found in the tumor at the moment of progression to sorafenib. And due to the MET amplification that we identified with the whole genome sequencing, we decided to treat the patient with tepotinib, that is a MET inhibitor. And we collect plasma samples over the time, and patients experienced a complete response to tepotinib. And in the plasma sample that we collected when tumor was inactive, because patients had a complete response, we were not able to find any mutation, but the mutation appeared again when the patient progressed to tepotinib. And when the patient progressed to tepotinib, we were able also to find a new mutation in beta-catenin. And the case of the second patient is always a man with alcohol and HCV-related cirrhosis. The patients entered a clinical trial in France that's called Nivolet, that consists of perform a first biopsy after the patients undergo 2 infusions of neoadjuvant nivolumab and a reversible electroporation, and after that, monthly injection of nivolumab for 1 year. So we analyzed the first tumor, and the first tumor at the moment of the biopsy, and the first tumor was mutated in TERT promoter and in TP53. And this mutation in TERT promoter and TP53 were not detected in the plasma sample during the adjuvant or neoadjuvant treatment, except for the plasma sample that we collected after 24 hours from the local regional treatment. I didn't show you, but we analyzed also all the plasma that we collected 24 hours after local regional treatment, and we observed that we have a better concordance between circulating tumor DNA and tumor 24 hours after treatment, probably because the necrosis induced by the ablation released the more circulating tumor DNA in the bloodstream, so we are more sensitive. And these mutations were found only 24 hours after treatment, but at the 14th injection, we were found again, this mutation, and 14 injection, that is 3 weeks before the evidence of radiological progression at the imaging. And at the radiological progression, we observed also a new mutation in beta-catenin, and all these mutations were detected at least in the first 4 plasma that we collected at the atezolizumab bevacizumab. Unfortunately, in this part of the work, we didn't analyze the other because the plasma didn't arrive in time to the lab, but the patient experienced a complete response. So we collected again the plasma, and we are looking for searching again this mutation and trying to see if over the time this mutation disappeared. And so to summarize a little bit what we can explore in systemic treatments in terms of circulating biomarker, we know that alpha-fetoprotein is the most widely used, is the most known and used in clinical practice. But we don't have only to focus on the baseline levels, but we have to observe, and what we have seen is that we should studies also the dynamic of alpha-fetoprotein. And because we observed that a reduction of more than 20% at 3 weeks is associated with a high rate of radiological response and longer overall survival, that alpha-fetoprotein, it's not enough, it's not the solution, and so we have to combine it with other biomarkers. One biomarker could be the ALBI score that helps the clinician to classify also the liver function of the patients, but moving towards the field of personalized medicine, I think that we have to think more to the circulating tumor DNA, because we know that we have circulating tumor DNA concentration and the percentage of mutation is associated with BCLC stage, and so is very high in percentage, very high in patients with BCLC advanced stage. And that in patients treated with atezolizumab bevacizumab, at least for our experience, the persistence of mutation detected at baseline in the plasma samples collected at the first radiological association is associated with progression to treatment. And so it could help the clinician, and the circulating tumor DNA could help us into changing strategy before the radiological evaluation, improving the treatment, the overall treatment management of the patient. And with that, I've concluded, and I'd like to thank you all for the attention.
Thank you so much, Claudia. Really, really nice presentation.